Okay, so hello everyone and welcome to BrainMap. It's my great pleasure to introduce our speaker today, Dr. Sana Raoof. She's a graduate of the Harvard MD PhD program with a strong interest in early cancer detection. Her graduate research at MGH Cancer Center focused on drug development for oncogene mutant non-small cell lung cancer, developing resistance to targeted therapies. She subsequently became involved in the development of multi-cancer early detection technologies via DNA methylation-based liquid biopsy. She's a resident physician at Mass General and provides medical testimony at New York and Massachusetts state and local government in favor of anti-tobacco legislation of varied forms. For scientific and policy efforts, she was awarded the Intel Young Scientist of 2008, received the 2015 National Excellence in Public Health Award from the Surgeon General, and was on Forbes 2020 list of the 30 under 30 in healthcare. I would just like to remind the audience to please address any question you have using the Q&A box. Dr. Raoof, thank you very much for coming here today. The virtual stage is yours.
Thank you so much. I want to give a quick background on why I'm particularly excited to be speaking today to the Martinos Center. As you just heard, my interest is in oncology and particularly in early cancer detection. And as you will all hear, I think that the future of next generation cancer screening efforts is actually going to rely heavily on innovations in radiology. And so I wanted to reach out to this audience, make you aware of some of the technologies that are on the horizon in early cancer detection, and then start brainstorming with all of you at the end of this talk about some of your ideas. So the topic of this session is going to be cancer screening, looking beyond scopes, scans, and smears. A little bit of background about my research. During my PhD at MGH Cancer Center, I was actually in your building at 149 13th Street, and I was studying lung cancers that have a mutation in a gene called EGFR. Now, this accounts for 15 to 20% of non-small cell lung cancers, and unfortunately, it's a disease predominantly of non-smokers, and it's most common in young Asian women. Now, the important thing that I want to tell you about this disease is that since there's a mutation in an oncogene, EGFR, it belongs to a category of cancers that can be treated with targeted therapies that go after specific mutations. So in this case, EGFR targeting inhibitors extend progression-free survival compared to chemotherapy from around 6 months to around 11 months, and they have an incredible side effect profile. They're very well tolerated. But the problem in the field of oncology is that no matter what the drug is that we have developed so far, it has always been susceptible to the development of resistance. And the mechanism that cancer cells evolve resistance across classes of our best drugs is just a process of microscopic natural selection. The vast majority of cells in a cancer might die when we apply the pressure of some drug to them, but there'll always be a few cells left behind which can survive by some mechanism. Those cells eventually grow out and form entirely resistant tumor populations. And we can try different drugs after that or different drug combinations, but of course the process of natural selection never ends. And so this kind of is the reason that we are not really able to cure any metastatic cancers at this time. And so, this is a great problem in the field of oncology. I kind of went through my PhD focused on drug development and came out of my PhD thinking, wouldn't it be better if rather than focusing on better and better drugs for the end stages of cancer, if instead we focused our efforts on catching these cancers before they're metastatic and before we have to rely on drugs. If you catch a cancer at a localized stage, then you're not reaching for drugs. The first thing you're reaching for is a surgeon or a radiation oncologist. And so my disclosure is that I have a variety of funding sources for my studies in cancer early detection. One of them is a biotech company called Grail that's designing a multi-cancer early detection tool. So with that background and motivation, let's begin with a brief review of the last 5 decades of American oncology. American investment in cancer research really launched in 1971 when President Nixon declared a war on cancer and established the National Cancer Institute. And since then, we've spent about $110 billion in basic cancer research. This is entirely separate from the amount that we spend on clinical care of cancer patients, which is about $150 billion annually in today's currency. Now, based on research funded by the NCI, we know that about 45% of cancer deaths are preventable, and they're linked to risk factors like smoking, obesity, and other exposures. Ironically, only about 6% of the budget is devoted to cancer control and prevention. The vast majority of our budget is spent on drug development. And we have done a lot of great drug development in the last 50 years. We came up with the first monoclonal antibody therapies that are used in cancer, like trastuzumab for HER2 mutant breast cancer. We came up with the very first targeted therapies like Gleevec, which is a tyrosine kinase inhibitor used for CML. We also came up with the Cancer Genome Atlas, which totally revolutionized our genetic understanding of cancers. Finally, in 2016, there was another huge investment into the world of American oncology by Vice President Biden, who launched the Moonshot Initiative to quote unquote double the rate of progress against cancer. And we reached another great milestone in 2017 when the NCI declared that cancer mortality has dropped 29% since its peak in 1991. These are curves of cancer mortality across the most common subtypes of cancer in men and women. As you can see, this big orange curve here kind of dwarfs the effects of all the others. This is lung cancer mortality in men. The rise and fall of smoking prevalence in the United States is 30 years shifted back from the rise and fall of lung cancer mortality in American men, and is also very strongly associated with the rise and fall of lung cancer mortality in American women. So the point I'm trying to make is that we've had a lot of big achievements in American oncology so far, particularly in the realm of drug development, where most of our money is invested. But the biggest effect so far in reducing cancer mortality actually came from a primary prevention effort. So where are we today? Cancer is the leading cause of death in Americans under 80, the second leading cause overall. One of the things that can kind of give us hope when we think about how we can improve cancer outcomes in the future is this statistic. 5-year overall survival, 5-year cancer-specific survival is 89% when cancers are caught early at local stages. It's only 21% across subtypes when we're caught at metastatic stages. If you look at this by the different types of cancer, this is kind of a trend that's true when we look at the extremes of indolence, like prostate cancer, or aggressiveness, like pancreatic or liver cancer. Basically, no matter what the subtype of cancer is, the outcomes are extremely different in localized tumors versus metastatic tumors. And so in order to try and realize the benefit that you get of early detection of cancer at localized stages, the United States Preventive Services Task Force recommends a variety of standard cancer screens for an American adult. Now, there are 3 cancer screens that are currently recommended for an average American adult. This is cervical cancer screening, colon cancer screening, and breast cancer screening. If you're a heavy smoker of a particular age, you also qualify for lung cancer screening. And many of you may be wondering about prostate cancer screening with PSAs. That's no longer recommended per se. What is recommended is that patients and doctors have a conversation about whether the PSA test is right for them. In addition to these standard screens, the United States currently has a variety of high-risk screening programs. For example, people with a strong family history of pancreatic cancer can get abdominal MRIs. People that have known Barrett's esophagus can get esophageal cancer screening with upper endoscopies. People that have known liver diseases like cirrhosis can get liver cancer screening for hepatocellular carcinoma. But the problem with all of these programs is that depending on the type of cancer, 90 to 95% of deaths are happening in people who were never part of special surveillance programs. Most people don't know that they're high risk for one type of cancer or another. And so it's very hard to utilize these programs at a level that makes a substantial impact in overall cancer mortality. What we do know from these programs is that people who are enrolled in special surveillance end up being diagnosed with earlier stages of cancer and have improved 5-year mortality outcomes compared to people who weren't enrolled. Now, the real punchline of this entire talk that I'm giving you is kind of encapsulated on this slide. This is the problem with the current screening programs in the United States. 79% of cancer deaths are happening from cancers for which we lack standardized population-wide screening. And so, doctors, primary care physicians are looking where they can, where we have the tools to look, which is in this 21%. But the vast majority of deaths are looking in places where we currently don't have screening. And even the cancers that we do have screening for, like lung cancer with low-dose chest CT, there is extreme underutilization of the screening program. So for example, only 30% of people who end up being diagnosed with lung cancer would have qualified for screening based on the smoking criteria. You need to have smoked 30 pack years to qualify. So of the 30% of people who could have been screened, fewer than 2% are actually getting annual screening. And the reason that Americans aren't utilizing their available cancer screens at an optimal level is multifactorial. The biggest reason that people report is just inconvenience. We have a variety of different cancer screens that are recommended to Americans roughly between the age of 50 and 80. You might have to miss work, keep going back to hospitals in order to get your colonoscopy, to get your mammogram, to get your pap smear, to get your LDCT. Some of these are also uncomfortable. People don't love getting colonoscopies. People don't love getting mammography. There are also other concerns like radiation exposure from mammograms. Ironically, people who've smoked 30 pack years can still report that they're scared of radiation exposure from a low-dose chest CT. And then finally, primary care physicians have a lot on their mind. They're not just thinking about your cancer risk, they're thinking about, cardiovascular disease, as well as everything else that you have going on. And so a lot of these cancer screening tests, which are all prescribed on different schedules for different people, may not just get ordered on time. And so there might just be medical oversight that causes people to not be screened optimally for cancer. So if we think about the next generation of American cancer screening and how we can improve upon the scopes, scans, and smears that we currently use, we can start with basic principles of what would make for a good test. One thing that I can say is that cancer is very common. Half of men and a third of women in this country are diagnosed with some type of cancer in their lifetime, but no one has any idea which cancer they're going to be diagnosed with. And so designing a test that actually searches you for multiple types of cancer at once, or a hypothesis-free cancer screen, would in theory be the ideal approach. We don't have anything like this so far, but a lot of these types of tests are in development, these kind of multi-cancer or pan-cancer detection tests. And the two things that really stand out when you compare test performance for a single cancer test versus a multi-cancer test are number needed to screen and positive predictive value. These are really important concepts when we think about cancer screening. When the United States Preventive Services Task Force does a cost-benefit analysis to figure out whether a test is worth using on a population level, they think a lot about number needed to screen and PPV. So of course, we all understand the concept that the more prevalent a disease is, the fewer people you need to screen in order to find it. So if you look at number needed to screen for GI malignancies, for example, you'd have to look through 167 American adults between 50 and 80 to find one case of colorectal cancer at any moment in time. We consider that to be within the realm of reason, and so we do screen for colorectal cancer in people with colonoscopies and a few other alternatives to colonoscopy. If you look at pancreatic cancer, however, you'd have to look through 500 people. Based on that number, the USPSTF determined that only people who are at very high risk for pancreatic cancer should be screened. And so we rely on family history or known genetic mutations to select people to offer pancreatic cancer screening to. Unfortunately, we don't find the vast majority of people who actually get pancreatic cancer to enroll in these special programs. If you look at esophageal cancer, a terrible cancer to get, even if it's cured, the effects of the therapy can make it really hard to swallow, to chew, or to live for many years after your esophageal cancer might be cured by radiation. You'd need to look through 1,000 people to find a single case of esophageal cancer to try and catch it early in a systematic way and treat it in such a way that doesn't actually ruin someone's quality of life. So these numbers are just tough. When we look for rarer and rarer cancers, the cost versus the benefit seems to be greater and greater. If there was a test, however, that looked for all GI cancers, you'd only have to look through 83 people before you found one case. In theory, with a perfect test, if you were just looking for any type of cancer, you'd have to look through 33 American adults to find one case of active malignancy. And similarly, the power of aggregate prevalence, if you could just group all of the cancers that exist together and look for them with one test, aggregate prevalence would also be of huge benefit to positive predictive value. We know that the PPV of the test is determined by the specificity of the test and the prevalence of the disease. And so if you look at this on a graph, look at this curve with a specificity of 99%. I'll show you all a bunch of multi-cancer early detection technologies that are in development. The majority of them are being developed so that they have a very high specificity, actually above 99%. And if you look at the PPVs, based on the prevalence of the disease, whether we're looking just for esophageal cancer versus looking for any cancer, the PPV skyrockets. And so in theory, if you're using a test that looks for any cancer and has a 99% specificity, your PPVs are up here in the 70s, nearly 80% range. Compare this to the PPVs of our current cancer screens. The PPV for mammography, for example, is about 4.5%. The PPV for the most common cancer in men and women, the most common cause of cancer death in men and women is lung cancer, PPV is under 4%. And so, this creates a lot of struggle for primary care physicians and for specialists who are looking at these tests. You have a positive test, but the PPV is only 4%. You're not necessarily sure clinically what to do with it. And this leads to underutilization of these tests as well. So I've explained to you guys all, based on a few basic principles, why it would be really useful to have a test that looks for all cancers and not just for the few cancers that we currently have population-wide screens for. Another thing to consider is the patient perspective. Every test that you get, there's a risk of false positive. And for every false positive, there's a risk that you're going to get a biopsy or some kind of unnecessary follow-up imaging, which can also cause harms. And so having a streamlined approach to look for multiple cancers at once exposes you to fewer false positives, as long as the false positive rate of that one single streamlined test is pretty low. And so there's a variety of reasons why we should be interested in looking for some kind of multi-cancer early detection approaches to enhance screening efforts in the United States. But how can we possibly do this? So far, we've only been able to look basically one organ at a time. Well, I think that to answer this question, we can learn a lot from the world of therapeutics, which is much more modernized and sophisticated than the world of screening at the present time, at least in oncology. In 2011, Professor Bob Weinberg at MIT wrote an incredible paper called The Hallmarks of Cancer. There were two versions of these papers. One updated the other. In this paper, he kind of lays out the various traits that a cell needs to possess in order to become a cancerous cell. So for example, a cell needs to sustain its own proliferative signaling. A cell needs to avoid immune destruction. Cells need to be able to activate invasion and metastasis cascades. And based on these hallmarks of cancer, there have been dozens and dozens of new therapeutics that are designed that can work across many different types of cancer because they're targeting these features that are common to many different types of cancer cells. At the current time, there's about 600 anti-cancer drugs that are approved by the FDA. And in general, the world of drug development is just exploding with new genetic, epigenetic, and immune targeting compounds. In comparison to this, the world of screening really lacks any insights from molecular biology, from genetics, from epigenetics, or from the immune system. The three, again, population-wide tests that we recommend are pap smears, which is developed in the 20s to 60s, recommended in the 60s. It's based on cytology. You basically do a cervical smear and look under the microscope. There is mammography, which is based on ionizing radiation, initially developed in the 60s, recommended in the 70s. And then the gold standard for diagnosing colon cancer is colonoscopy, again, developed in the 60s, popularized in the 80s when it was used repeatedly on President Reagan to excise his polyps, and then finally recommended in the 90s. And this is a tool that uses direct visualization. So we really aren't bringing too many genetic insights into our standard cancer screening tools. And there's no reason that the biological hallmarks of cancer, which are used to design better and better therapeutics for the end stages of cancer, can't also be used to inspire next generation multi-cancer screening. So one of the things that's really exciting is kind of this growing body of literature on all of the things that cancer cells secrete into the bloodstream. The major things that people are studying are proteins, DNA, both for its sequence as well as for its methylation pattern, and RNA. There's also extracellular vesicles. And there's 4 kind of giant efforts that are currently underway at looking at things that cancer cells secrete into the blood to try and catch multiple different types of cancer early at the same time. So the tech company that I work with is Grail. They're based on DNA methylation. And then 2 other tech companies called Thrive and Freenome are based on DNA sequencing and proteins. And then there's an academic lab at Stanford run by a radiation oncologist named Dr. Max Dean that's also trying to develop these types of tests. So I'm going to tell you about the basic scientific premise of the different tools that are currently in development and where they are in the pipeline of translation to the clinic. So Thrive and Freenome have made multi-cancer early detection tests based on DNA sequencing and protein biomarkers. These tests have been designed in such a way that you are able to filter out signals of clonal hematopoiesis from the blood. Many of you might be aware of this literature. Basically, Americans above the age of 60 have a high prevalence of clonal hematopoiesis, which is a totally benign process where some cells in your white blood cell compartment have started to expand in a clonal way, and it creates a clonal signal that can look like cancer, but in fact, it's a totally benign process. And so these tests that are based on circulating tumor DNA need to filter out that benign clonal hematopoiesis signal. And the way that they have done that so far is that there's actually a 2-part blood test that happens. First test, if it creates a positive signal, you go back for a second test, which is used to filter out false positives from this clonal hematopoiesis process. Now, another thing that's kind of specific to these DNA and protein-based tests is that because all of the cells in our body roughly have the same DNA sequence, these tests don't tell you where in the body a cancer signal is coming from. They can tell you that there is some clonal signal that looks like a cancer somewhere. But once you get that signal, you have no way of knowing based on that blood test alone, is it coming from your liver, your kidney, your eye, or your bone? And so these DNA-based or protein biomarker-based tests currently produce a cancer signal, but no tissue of origin. And so this is where the world of radiology is being invoked. The makers of these tests suggest that everyone who gets a positive signal actually get a reflex workup with a PET CT. And we'll have a big and I'm sure colorful discussion about whether that makes sense later in this talk, but that's the first way in which the world of radiology is going to kind of really be affected by these tests if they're ever to hit clinic, is the use of nuclear medicine to try and work up positive tests for cancer in totally asymptomatic screening populations. Now, the other type of test that is currently in clinical development is based on methylated DNA. This is made by the company Grail. Now, the thing that I liked most about this test that attracted me to Grail compared to the other companies is that because every tissue type in our body has a unique methylome, if you have a cancer signal based on methylated DNA patterns, you also know which tissue that signal is coming from. And so these types of tests, upon producing a positive signal, can be followed up with some sort of targeted radiologic workup rather than doing a hypothesis-free full body scan. For example, if you get a positive signal and it says that it's coming from the lung, you could follow up with a chest CT. This is kind of the proposed targeted workups for every different tissue of origin that could be generated by Grail. Now, other things that are special in these methylation-based tests, it seems that methylation changes in the area of tumor suppressors and also of oncogenes are some of the earliest things that happen in carcinogenesis, actually, before DNA mutations take place in cancers. Dr. Bob Weinberg told me that he doesn't have the energy or the time anymore to write a third paper updating the hallmarks of cancer with altered methylation as a modern hallmark of cancer. But if I have the energy, I can do that. But the point is that there's a good body of literature in development now suggesting that altered methylation patterns on CpG islands in circulating tumor DNA is really kind of universal across many different types of cancer. And finally, one more feature of methylated DNA in the bloodstream of cancer patients. It seems that cancers that are more aggressive really shed a lot more methylated DNA into the bloodstream. And so based on clinical studies so far on methylated DNA based liquid biopsy, it seems that these tests specifically catch cancers that will go on to kill patients rather than catching cancers that are of more indolent varieties, which is kind of relevant in the field of cancer because many of you may have heard there's a lot of overdiagnosis in oncology that ends up hurting patients more than helping them. A great example of this is prostate cancer screening with the PSA test. And so, you know, any test that kind of specifically catches aggressive disease, especially at earlier stages, is going to be exciting to a modern oncologist. So anyway, I've told you all about a few different types of multi-cancer early detection tests. Now I want to tell you where they are in their clinical pipeline and how likely are they to actually affect, you know, the life of radiologists or people who are working in the field of imaging and designing next generation imaging technologies. The punchline is that it's pretty likely to surface in clinic, and we're all likely to hear about them in the next few years. This is a snapshot of a variety of clinical studies that are happening with the company Grail. Two of these studies, Strive and Pathfinder, are actually enrolling in Harvard hospitals, in Dana-Farber and Mass General. And so we're all likely to hear about some of the data that comes out of these studies in the next few years. And now, this is the most important part of the talk. I'd love to open it up for discussion. I'm going to talk about how these next generation screening tools will make an impact on radiology, on clinical trials design, and on healthcare economics. So let's start with radiology, which is most relevant to everyone here. You know, as you can imagine, based on the way that these tests work, a positive signal would be very confusing for physicians in the current healthcare system. We have never used tests for multiple different types of cancer at the same time. We don't have very good blood tests for cancer other than the PSA test, which is still the focus of a lot of controversy on whether or not we should even be using it. Other than that test, the other tests that we use as gold standards for cancer screening are not blood-based. And so there's going to be a lot of reliance from the world of primary care and oncology on the world of radiology to try and give answers on what we should do next once a positive test for cancer in an asymptomatic person is generated. Now, in the world of no tissue of origin, PET-CT is currently the proposed approach for how to work up a positive test. In the world where there is a tissue of origin proposed, you might want to do a targeted workup, but what if you look in that organ and you don't see anything? The PPVs for the GRAIL test and the THRIVE test have been reported in the high 30s to 50%, depending on the test that we're talking about. That's a very high PPV, and it would make it difficult for a doctor to ignore that positive signal, even if they look in the organ where the cancer is supposed to be coming from and they don't see anything there. A doctor would be compelled to think, well, maybe the imaging just isn't good enough and there actually is a pancreatic cancer at an early stage. And if I don't do something about it, this person is going to have metastatic pancreatic cancer or locally advanced pancreatic cancer, and the outcomes will become much, much worse. And then we will look to the radiologist and also to the scientists who are making better and better imaging tools and say, you know, what can we do? What's the most sensitive test? What are the algorithms that we should use in this situation? Some of the basic questions that come up in this world are, you know, what would be the benefits and what would be the harms of invoking PET-CT as a reflex test in a screening environment if we're talking about a PPV of 30 to 50%? What are your thoughts about, you know, the radiation risks if we expose a general population to 20 to 30 millisieverts of radiation when they're totally asymptomatic? At what PPV would we consider using a PET-CT? Is there an appropriate cutoff? And how realistic would this be in community centers? So before I go on to the next part of this discussion, which is about clinical trial design, I'd love to kind of stop for questions and some discussion here.
Okay, so Sana, we have a quick question from Dr. Anand Kumar. How much blood does a typical liquid biopsy require?
That's a great question. So right now, about 10 mils.
Thank you. Dr. Kumar, you can also speak if you have any other question. If anyone has any other question, please feel free to type in the chat or in the Q&A. Oh, just a sec. So Bruce Jenkins, can you try and unmute?
Oh, yeah. Hi, I was just curious. You know, it seems to me that a specificity of even 99% is probably not high enough, because it's not just a matter of finding the tissue of origin, because it's unlikely that the test that has, at least so far, THRIVE and GRAIL have published results that don't detect a huge amount of early stage cancers. And then the other problem is that there's a few tissues for which the origin can be specified, but a bunch of that you can't. And so I think that it seems to me that a 99% specificity is nowhere near high enough when you start piling on the cost of doing PET scans to this huge number of screened subjects. So in other words, I guess the real point is it seems like we're in the very early days. And from what's been published, I don't see these tests being even close to being economically feasible.
Yeah, I mean, that's a great point. They are very, I mean, there's absolutely no studies on how they ultimately affect cancer-specific survival or anything that would be clinically relevant enough for the FDA to consider approving them. I will say that, so the study published by GRAIL is the one that has a PPV of about 51 or 52%, and does do a slightly better job than THRIVE at catching earlier stage cancers. I think the sensitivity at stage 1 and 2 is around 30 or 40%. And I think one of the key things that I find compelling in these technologies, even though they're at their earliest stages, is that if we want to make some kind of dent in cancer mortality in the United States and make qualitative differences, we kind of have to start somewhere in the effort to detect things early, and we have to stop thinking about what to do in the latest stages of cancer. And so far, these seem to me like the best things that exist today in trying to catch many different types of cancers at once. And in simulations that have been published as recently as December, you know, even the way that these tests are performing now in their preliminary clinical studies that you've read, they would increase the number of early stage cancers diagnosed in the United States by about 4-fold. And that would have, you know, that projected to have, you know, a huge impact on overall cancer specific survival. So, I mean, that is completely theoretical. But I think what I'm trying to say is I agree with you. They're early in their clinical development, but there's nothing else that I think exists today that is anywhere close to as promising as these. And so I feel like, at least for me, it's been exciting and definitely worth the effort to invest some kind of time and effort into thinking about how could we ever implement these things practically. And also to kind of compare them to the tests we are using. The sensitivity and specificity for these tests are, even in their infancy, quite a bit higher than the tests that are already approved. So the specificity of PSA is around 80% if you use the standard PSA cutoff of 4. The specificity of breast cancer screening with mammography is in that same ballpark. And that's why the PPVs are also extremely low for these tests. So, I mean, I agree that these multi-cancer tests will create a nuisance, but I'm not sure that we have anything really better to focus our efforts on right now. And I think they'll create less of a nuisance than the tests that we currently use. As for the economic thing about PET-CT, I think it's very unlikely that anyone is going to want to use PET-CT as a reflex workup in people who are asymptomatic. It's really expensive. There's a lot of radiation exposure, and there's not a lot of PET scanners that exist in this country that aren't already tied up with patients that have established cancer diagnosis and need staging scans. And instead, to allocate, you know, time in a PET scanner to people who have no symptoms and may not even have cancer, it seems like a really far-flung idea to me. But just in December, in the Senate and the House of Representatives, a bill was introduced proposing Medicare and Medicaid coverage of multi-cancer early detection tests contingent upon FDA approval, which means nothing. It's totally symbolic until the FDA approves them, but it signals a growing interest from regulatory bodies in this technology. And so I think it's really important for people in radiology to start thinking about, you know, if these things were to get contingent approvals, what should we do to work them up? I think a lot of people will be looking to the radiology community to give comments on, is a PET scan appropriate, or should we use targeted tests? And if the targeted tests are negative, then we give up or we come back at some kind of interval and look again. So I haven't really answered your question other than to say those are really good points, and it's a hairy situation and a very active situation right now. A lot of interest in the field and a lot of investment right now. Do you have any ideas about what you would think is an appropriate PPV cutoff to actually move to a nuclear scan?
I don't know, because, like, for instance, if you look at you know, colon cancer screening, you know, one of the reasons that you can do, you know, and when they do the economic modeling, like, I don't know if you've noticed, but the FDA has just put out new guidelines for blood-based liquid biopsy tests for colon cancer screening. Yep. And they basically have to mirror the performance of the fecal immunotest, which is like 74% sensitivity to early stages cancer and better than 90% specificity. But, you know, that's a unique situation because there you have a tool that you can use to get rid of the early stage cancers, colonoscopy. And so, in other words, you can prevent. But I think for a lot of these cancers, you don't have that same economic kind of value for the early detection and early removal. And so when you have something that's like 30% sensitive for early stage cancer, I just can't see on any planet how that would ever be economically viable as a general screening tool until performance gets, I don't know the number off the top of my head, but it's got to be pretty darn high for, I think, any kind of radiographic screening. I mean, much higher than where things are now. And but that's just my opinion.
Yeah.
And certainly, I agree with you that this is the place to go to find the right solution. But I just think the performance characteristics are not economically viable. But that's just my opinion.
No, I mean, that's a really valid opinion, and that's an opinion that I think the FDA is voicing. And I think one thing that I'm hearing from you is, compared to the sensitivity for early stage colon cancer, which can be in the 70s or 80% with blood-based tests, the sensitivity for all cancers with these tests is in the 30s and 40s. And that's a big discrepancy. I think one of the big challenges in the world of multi-cancer early detection is to try and shift our thinking about sensitivity, which is single cancer specific, to thinking about cumulative cancer detection nationally. So, any test that is optimized to just look at one organ will probably, always be better in terms of sensitivity for looking at cancer, and that's one single organ, compared to a test that's designed to just try and find as many different cancers as possible. And so 30% sensitivity for all early stage cancers would still result in a lot more early cancer diagnoses than a test that's 80% specific for any individual cancer, even the most common individual cancers. And so I think, you're voicing kind of a crux of the field, and the assessment and regulation of this entire field is going to come down basically to try and change the way that people assess technologies, and to not think so much about sensitivity, but to think about cumulative cancer detection at early stages, and to think about how many people will be stage shifted from late to early stages across all subtypes, and how many lives might that save, even if the sensitivity for any individual cancer is a lot less impressive than the sensitivity of the tests designed for that one single cancer.
Well, do you guys have like a quantitative metric that you're using to characterize the ability to describe the tissue of origin? Because I think what you're saying, is fine, and it makes some sense if you actually have a good way of characterizing tissue of origin. If you don't have a good way of characterizing tissue of origin, or if the quantitative ability to characterize tissue of origin is low, then I don't think it matters that you can detect, 30% across a wide range of cancers. Because somebody's going to come in, they're going to say, well, you got cancer somewhere,
Yeah.
and we know that you have cancer somewhere, but I don't know. That to me is it's again a non-starter from an economic point of view, and a actually psychological cost point of view also.
Yeah, no, I totally agree. I mean, I think that's a large issue with Thrive, that can't predict tissue of origin and relies on PET-CT. In terms of GRAIL, I think the exact numbers reported are that in 96% of cases of a positive test, a tissue of origin was reported. And of the 96% of times when a tissue of origin was reported, around 90% of the time it was correct. And so overall that comes to, or like in the high 80s, around 88% of the time, you get a correct tissue of origin when you get a positive test. And so, this is currently an active question. It's an ongoing conversation between GRAIL and the FDA, kind of about what should we do when we get a positive with a tissue of origin, and we look in the area where the tissue of origin is reported, but there is no cancer there. Do we need better imaging? Are we just detecting cancers that are really early stage and we can't see them? Or is it a false positive? Should we come back at a particular interval? Should we do a PET-CT? I mean, you're asking all the right questions, and you've kind of like hit the question right on the head. The biggest question with these tests is how can you possibly follow them up? So I think, and there's absolutely no precedent for these types of screening tests. So I think the imagination of people who are in the field of radiology will be really useful in terms of figuring out how should we even assess these tests and how should we follow them up. I don't have really any better answer for you than these are really just all in their theoretical stages of how to clinically implement them. That's really my only answer.
Thank you.
Does anyone else have any questions or comments about this topic? Here were some conversation points. Okay, if not, then I will move on to another field that will be kind of an area of opportunity when multi-cancer early detection tests are kind of later on in their clinical trials. One question is, how do you design a good clinical trial to figure out the impact that these multi-cancer early detection tests are having in cancer outcomes? One of the big things that has happened in cancer screening is that we've relied on randomized control trials with mortality or survival endpoints. For example, one of the biggest oncology trials in American history was PLCO, cost about $500 million. It went on for well over 20 years. And two of the arms, the prostate and the ovarian screening arm, came to completely different conclusions than the analogous trials that were done in Europe and were just as long, were actually even bigger in terms of enrollment numbers, and were just as expensive. And the problems with some of these historic RCTs in cancer screening were simple things like, in the prostate cancer screening arm of PLCO, we find out that over 90% of people who were in the control group actually got screening anyway. And so rather than comparing screening to non-screening, we were comparing screening to screening and got a negative answer. The trials in Europe came to different conclusions because they didn't have that contamination of the control arm. In ovarian cancer screening in the United States, using a particular biomarker called CA125, the American trial used a global cutoff value of the biomarker and found that that didn't improve outcomes. Whereas in Europe, rather than using a static cutoff value, they instead used a more personalized approach developed by a statistician named Steve Skates, where they were looking for exponential increases in CA125 in women. And each one was personalized to the woman's baseline. And that actually showed a substantial effect on stage shifting ovarian cancers, catching them earlier and having better outcomes. And so these trials are hairy, they take a long time, and they don't always come to kind of consistent conclusions. This is the reason why PSA testing in this country is grade C, which means we don't have enough information to give you a straightforward recommendation. Basically, it's up to you and your doctor, have a conversation about it. And we don't currently recommend ovarian cancer screening based on the studies available to us. And then finally, by the time these studies are done, maybe two decades have passed since the intervention was initially developed, and there might be new interventions that exist that are being studied that might be better than the thing we were initially trying to study. And so the point I'm trying to make is that screening for cancer in healthy populations takes decades, because healthy people don't go on to develop cancer and die from it for decades. And so RCTs for screening just cost much more and take much longer and are riddled with a lot more errors than RCTs in the therapeutics world. If you have metastatic cancer, you're not likely to live for decades, no matter what type of cancer it is. And so drugs that are compared in the metastatic setting can be compared effectively with mortality and survival endpoints in RCTs much more quickly. And so there's huge disincentives to people kind of running RCTs in the early detection space compared to the therapeutic space. And so there's been a lot of kind of interest in the FDA in the last few years to try and incorporate other types of data that can be used to assess medical devices. And, oh, sorry, did my screen share just go away?
Now we see it.
Interesting, I can't actually see it. but I'll keep talking while I figure this out. So there's been a lot of investment from the FDA in trying to figure out whether we can use surrogate endpoints of survival, basically other things that we can measure other than mortality and survival that could give us a hint about the ultimate impact on mortality or survival, in order to come to earlier conclusions about a variety of different devices or interventions, and then have conditional approvals based on these earlier studies, and say that as long as we continue to generate real world evidence in support of their efficacy, we will continue to approve them and pay for them. And so this is kind of an unexplored area in the world of cancer screening. If you look in the literature of surrogate endpoints for cancer screening, not for cancer therapeutics, you'll find probably fewer than 3 papers that currently exist in that world. And so again, if there are people in this audience that work in clinical trial design, in surrogate endpoints, or in statistics as it pertains to clinical trials, I'd love to hear ideas about using real world evidence and surrogate endpoints to assess screening interventions in cancer. Anyone in the audience involved in this? Okay, looks like we probably don't have any clinical trialists in the audience, but I've planted these ideas in everyone's head, and they're just interesting to mull over, even if it's not your research focus. And final thing that I want to comment on is, in the world of health policy and economics, there's a lot of incentives in clinical oncology and also in cancer research that kind of push people towards the metastatic setting. One of the most basic things is that doctors who treat cancer, like medical oncologists, surgical oncologists, radiation oncologists, are just paid far more than primary care physicians whose job it is to prevent cancer or catch cancer early. There's also not really any metrics that exist for if a doctor is doing a good job at preventing cancer or catching it early. There's no real reward system for doing a good job at this. And so there's quite a bit of interest from the health policy world in creating an incentive structure where we're not rewarded for treating late stage cancers, but we're actually rewarded for catching cancers earlier or promoting behaviors that prevent cancer from arising in the first place. As I mentioned earlier, the vast majority of cancer research funding from the NIH and the NCI actually goes to drug development, which is largely relevant into the non-early stage settings of cancer. And so, trying to find mechanisms to shift budget allocation to early cancer detection, to screening tools, and to diagnostics would probably also be a good place to start in terms of creating incentives for researchers to go into the early detection world rather than mostly into the drug development world. Now, at this point, I would love to just take questions from everyone on anything that was covered in this talk or other ideas about unmet burdens in cancer screening.
So thank you very much for this great talk. If anyone from the audience has any question, you can use either the chat or the Q&A. I'm gonna have like a general quick question. So if you could have a single thing that you could change in the way screening is done today, excluding liquid biopsy, what would you change?
I think what I would do is to try and simplify it so that people could kind of know in a simple way when are they due for their next cancer screen, and go and get a variety of cancer screens bundled together at one time. This is kind of a blossoming effort at Mass General to try and streamline and simplify cancer screening programs that are already approved so that people don't have to remember, oh, I got a colonoscopy, 3 years ago, there was a small polyp, I was supposed to come back in 3 or 5 years. I'm not sure. I also need a mammogram. I'm supposed to get it every 2 years. I don't know if I got it last year or 2 years ago. It's really hard for people to keep track of when they've had their cancer screens. And as a, a young physician at Mass General, I can also say it's not very straightforward for clinicians either to go through your chart, see when you had your screens, see based on what the last screen found when the next screen is due. I would try and find a way to kind of come up with a bundling system where people kind of all get a mammo, a pap smear, and maybe a fecal-based colon cancer screening, every 2 years or every 3 years, which might waste some tests, but would at least promote more utilization of these tests in a way that's easy for patients and easy for doctors, so that people don't accidentally go 12 years without having a colonoscopy and then get diagnosed with, a stage 3 colorectal cancer that's also started invading local structures. I think a simple screening test, a utilized screening test, is the best type of screening test. And so efforts to basically just bundle them and come up with a schedule that would be the optimal schedule for all of these screens combined would be the thing that I would most want to do.
Great, thanks. We have a question from Ben. Ben, can you please try and unmute?
Oh, sure. That was a great talk. Learned a lot about liquid biopsy, and it's cool to see its potential in screening. My question is, have GRAIL ever looked into the liquid biopsy method developed here can be used to determine if a cancer is responding to a therapeutic treatment or not?
Yeah, that's a great question. And actually, the world of liquid biopsy existed before it existed in the screening context. And GRAIL and many other companies, actually, when we're looking at response to therapy or tracking whether a disease has recurred, there's not just GRAIL, but also many other companies that exist in that space, and they are absolutely trying to figure out whether methylation patterns from circulating tumor DNA can be used to track response to therapy and recurrence of disease over time. That's a great question, and I think probably an easier use of this tool in many ways, because we know the disease we're looking for, which makes the questions of sensitivity and specificity a lot simpler if we're only looking for one thing. But yeah, that is a great idea for repurposing of this tool, and it's definitely something that they're working on.
Sure. Could I ask one more question?
Please.
So one of the interesting things, about gene methylation is that, methylation tends to increase with age, as does cancer. And so you tend to lose specificity as a function of age. Like, for instance, if you look at the colon cancer test, Cologuard, that has tests for methylated gene markers as well as KRAS, they find that the specificity in younger groups is very high, like 95%, and of course goes down as you go older. So I'm just curious as to how you guys are approaching that at GRAIL in terms of, is it the fact that this is a confound in older populations? So do you see an age-related effect, or can you you're doing deep enough sequencing that you can actually figure out the methylome?
That is a fantastic question. I think you have a great way of honing in on all of the questions that I don't have good answers to. These are all fabulous questions and all things that are being studied. So the most straightforward way to answer your question would be to give you sensitivity, specificity, and PPV values for these tests when implemented clinically, stratified by age. And that data will soon exist, but it doesn't exist yet, and I don't know what it is. So I wouldn't even be able to give you any kind of answer about, are these tests actually performing better in 50 and 60-year-olds compared to 70 and 80-year-olds? So that's a great question, and hopefully in the next 1 or 2 years, with enrollment into the clinical trials that are already underway, there'll be data that helps answer that question. But you're a very quick thinker, and I don't have an answer to that question.
Anyway, great talk. Thank you.
Thank you so much.
Can I ask a question? Oh, quick one. Great talk. So I was just probably a naive question, but I was just trying to understand where this might, where you envisage this fitting into the diagnostic setting. Do you think that the routine blood work that we get, annual physical, do you think that this can be integrated into that? Do you think that, so maybe you discussed the costs of this, but is it something that can be employed or deployed in a PCP office where, as part of the routine blood work, you can use the same on a different machine to look at to detect cancer? Is it something that's
Yeah, that's a great question. So I think right now this is all based on my imagination and discussion with other people and their imagination. It's totally unclear how much these tests are going to cost. None of them have kind of publicized a price tag yet. But I think the vast majority of people who are thinking about these tests and designing them are thinking about these tests, kind of creating value if they can be used at the point of care in PCP offices. Anytime you get, a basal metabolic profile or a CBC drawn so that you can get your annual cardiovascular risk kind of quantified by looking at your blood lipids and this and that, you can also get your cancer risk profiled. And so, in my imagination, the prospect of having an annual or a biennial test that's done at the point of care, doesn't require an additional trip to any kind of medical office, would be kind of the way to get the most impact from this test. But yeah, price has not been kind of discussed yet, and it has not been publicized at all from any of these companies. Coverage doesn't exist for them yet. If they're approved by the FDA, then they would be covered by Medicare and Medicaid. But the economics of this test, as well as the economics of the radiologic tests that would have to happen as their workup, are really kind of a mystery right now. But in my imagination, I would love to think that they could be used at point of care at some point.
Okay, thank you.
Thank you.
Okay, if anyone has any other question, please feel free. Sana, thank you again so much for this very thought-provoking presentation and great talk. And we hope to see you soon at the Martinos again.
Thank you so much.